Hello, we're Group 5, and we're going to present to you a patient with portal hypertension and varices. The objectives of this presentation is to introduce a patient case and formulate an appropriate treatment plan, to discuss the etiology and pathophysiology of portal hypertension and varices, recognize risk factors and common signs and symptoms, and develop non-pharmacological and pharmacological treatment plans. JK is a 55-year-old white male who presents to the ER via EMS with a 2-day history of vomiting and coughing out blood. He denies any fever, chills, syncope, or presyncope. Due to the excessive nature of the bleeding, he calls 911.
All of the pertinent objective information is listed for you here, but I just wanted to point out a couple very important things. He is 20% below his ideal body weight. He does have a past medical history of alcoholic liver cirrhosis and esophageal varices, status post-banding. He continues to drink 7 to 8 glasses of whiskey per day, and he is fairly hypotensive with a blood pressure of 89/62 currently. Continuing on with his objective information, he did have scleral icterus on physical exam, as well as mild ascites and 1+ pitting edema. However, he was ANO ×3 and showed no apparent focal deficits. With his labs, his sodium was a little low at 132, but his potassium was still normal despite the amount of vomiting that he was experiencing. His PT and his INR were elevated, as well as his total bilirubin. His AST was elevated, but his ALT was still normal. His albumin, prealbumin, and BUN were low, and his MCV was elevated as well. The first most life-threatening problem for this patient is going to be suspected esophageal varices, and that's indicated by him having 2 days of vomiting and coughing up blood in combination with him being hypotensive and having that past medical history of cirrhosis and varices that have been banded in the past. The goals are going to be to stop the active bleeding, obtain hemodynamic stability, and prevent complications. Acute management, the first thing we want to do is volume resuscitation so we can get that blood pressure up. Generally, crystalloids are to be avoided because they can worsen portal hypertension and esophageal varices, so we do recommend albumin, and the dosing is there for you. Next, for stopping the bleeding, we recommend initiating octreotide. The dosing is also there for your reference, and some alternatives would be vasopressin with nitroglycerin or terlipressin. The guidelines do recommend confirming the diagnosis by performing an EGD within 12 hours of patient presentation, and then either EVL or sclerotherapy to treat the hemorrhage. Generally, patients will be started on a PPI when they present with GI bleeding, but if they haven't been started on a PPI, the guidelines recommend pantoprazole 40 milligrams IV times 1 after the EVL, and then followed by 9 days of PO for a total of 10 days. The last thing for the suspected varices is SBP prophylaxis. We recommend initiating ceftriaxone 1 gram per day for a maximum of 7 days, just because right now the patient probably can't tolerate PO meds. Once they can, we recommend switching to ciprofloxacin. The guidelines do recommend norfloxacin, but it is no longer available in the United States. For monitoring and follow-up, we recommend frequently monitoring vital signs, especially in the acute stage, daily weights, and daily monitoring for signs and symptoms of bleeding and adverse reactions. The next problem for this patient is going to be his portal hypertension, and that's indicated by him having a history of varices as well as a current suspected variceal bleed, which indicates portal hypertension. The gold standard for diagnosis, according to the guidelines, is wedged hepatic venous pressure, but due to its invasiveness, the guidelines also say that the presence of varices can be used as diagnosis. The goals for this patient are to prevent further varices and bleeding by reducing that portal venous pressure. For management, first off, it's very important that the patient's blood pressure has normalized before we start secondary prophylaxis. The guidelines recommend initiating a non-selective beta blocker in combination with EVL that I mentioned on the previous slide. We do recommend starting nadolol 40 milligrams daily Propranolol is another option, but we chose Nadolol because it's once daily versus twice daily, and it also has less side effects than propranolol. But either is appropriate according to the guidelines, and they're both titrated to the lowest tolerated heart rate. You also want to repeat the EVL every 1 to 2 weeks until the bleeding has stopped, followed by an EGD 1 to 3 months afterwards, and then you'll do an EGD yearly after that. For monitoring and follow-up, you want to monitor for adverse reactions of the beta blocker, so drowsiness, insomnia, dizziness, depression, and fatigue, especially when you initiate and when you're titrating to the max tolerated dose. And then you want to follow up weekly for that EVL until the varices have stopped bleeding. The next problem on the list is alcoholic liver cirrhosis, and while we have it as number 3 during this acute stage, it's really important to get this under control because it is fueling the rest of his problems. He has a past medical history of cirrhosis, a child Pew class of C, and a MELDNA of 25 points, indicating a 14.5% 3-month mortality rate, and he continues to drink 7 to 8 glasses of whiskey per day. His labs indicate coagulopathy, increased liver enzymes, and increased bilirubin, which are all extremely common in patients with cirrhosis. The goals are going to be to prevent withdrawal while he's inpatient and then prevent further progression of the disease. While he is inpatient, we recommend initiating the CWAP protocols to prevent withdrawals. Generally, longer-acting benzodiazepines are preferred, like chlordiazepoxide or diazepam. However, lorazepam can be used as well in the acute setting. Lifestyle modifications are very important for this patient. Abstaining from alcohol is essential, and referral to a support group may be necessary for this patient to get him to stop drinking. Monitoring and follow-up, you want to monitor hourly for signs and symptoms of withdrawal, such as tremors, seizures, anxiety, tachycardia, sweating, and changes in his mental status. And withdrawal from alcohol can be extremely serious, so monitoring them hourly is very important. The last problem on the list for this patient is malnutrition. And this is indicated by him being significantly underweight. He also has low prealbumin, albumin, and BUN, which is seen in patients that don't have a great diet and that are generally malnourished. He also has an elevated MCV, which indicates thiamine and folate deficiency as well, and these are all very common findings in patients with cirrhosis. The goal will be to improve his nutritional status, prevent complications such as Wernicke's encephalopathy, and provide nutritional support as needed. For management while he is in the hospital, we recommend continuing thiamine. He was on it PO, but in order to prevent Wernicke's, we recommend 100 milligrams IV or IM for 3 days, followed by continuing his 100 milligrams PO daily. We also recommend adding folic acid, 1 milligram PO daily, and to continue his multivitamin that he was taking at home as well. We will also recommend referring him to a dietitian while he is inpatient, as well as sodium restriction to less than 2 grams per day, which may help with his mild ascites. Addition of diuretics may be needed in the future, such as a combination of furosemide and spironolactone, but at this point we just recommend sodium restriction since his ascites is mild. For monitoring and follow-up, monitor for signs of Wernicke's, and commonly it's a triad of ataxia, confusion, and ophthalmoplegia. Follow up with a dietitian or a nutritionist once discharged to continue his care. Lastly, we wanted to go over his admission meds and then his discharge meds. We recommend continuing his multivitamin and his thiamine daily, especially since he is malnourished. We also decided to keep on the omeprazole just because he could have had a GI bleed in the past, but it's important to follow up with him, see if he is having any signs or symptoms of acid reflux, because this also could be just a continuation from an inpatient medication at some point in his past. So following up on that would be important. And as mentioned, throughout the assessment and plan, we recommend adding folic acid and Nadolol to his medication list, and in the future, he may require some diuretics, but at this point, we're just recommending dietary modifications.
The background of portal hypertension and varices. In regards to portal hypertension, the majority of the blood supply to the liver comes from the venous system through the portal network. Portal hypertension describes the elevation of pressure within the portal system. Portal hypertension usually results from a manifestation of liver cirrhosis. According to the NIAAA, liver cirrhosis accounted for almost 30,000 deaths in the U.S. in 2007, which made it the 12th leading cause of U.S. deaths. In regards to varices, varices are formed when the high portal vein pressure is greater than 10 to 12 mmHgs. Approximately 50% of patients with cirrhosis develop gastroesophageal varices. Rupture and bleeding incidents also occur from varices, are major complications from portal hypertension. Portal hypertension include the following. You can have cirrhosis of the liver. You can also have blood clots in the portal vein. And then lastly, you can have veins which carry blood from the liver to the heart are blocked, which can cause an increase in the pressure. For the varices, it's also similar as well. You have severe scarring of the liver, blood clots which signify thrombosis, and then you have parasitic infections such as the one listed. Pathophysiology include vessels in the liver, which are blocked due to liver damage, and because of this liver damage, blood cannot flow through the liver properly. In the portal system, you have a high pressure that develops. Because of the high pressure system, it creates large swollen veins called varices, and varices can develop within the esophagus, stomach, and rectum. Varices can lead to bleeding and rupture complications as well. Factors for variceal hemorrhage include the size of the varices, whether they're large, medium, or small. And then also another risk factor is the child Pugh class. And then another risk factor includes the presence of variceal red spots. Within a network of veins called the portal venous system, high pressure buildup can result from what major etiology? A. Rupture of varices within the esophagus. B. Systemic bacterial infections. C. Healthy liver tissue being replaced by hardening scar tissue. Or D. Excessive stress. Number 1 is C. Healthy liver tissue being replaced by hardening scar tissue. And what happens is that due to liver damage, you have a backup of pressure within the portal venous system. And this is what is known as portal hypertension.
So signs and symptoms for variceal hemorrhage, they kind of mirror portal hypertension because portal hypertension is the cause and varices is the effect. So what you usually see is vomiting with significant amounts of blood, tarry black or bloody stools, and lightheadedness and loss of consciousness. In severe cases, there's the loss of consciousness. So the top three are, for those specifically. Towards the bottom is more blanket signs and symptoms for liver failure, like the jaundice, the dark urine, and the sudden weight loss. All of those are for liver failure. The top are definitely for portal hypertension and varices. So going into diagnosis for portal hypertension, that's usually measured by wedged hepatic venous pressure. That is the preferred method, and to describe it, that basically is when a catheter enters the hepatic vein, it wedges it into a smaller branch. And just so you know, this is an indirect measurement. This is not at all direct. It correlates with the portal pressure. So if you know the WHVP, chances are you know the portal pressure. And this could be used in both alcoholic and non-alcoholic cirrhosis. So when the intra-abdominal pressure increases in a person, this has to be corrected. So the way they do that is you take the WHVP and you subtract that from the free hepatic vein pressure, which is acronymed FHVP. So the typical range for that, or actually the result measurement, is your hepatic venous pressure gradient, and the range for that is 3 to 5. And when that's above 10, that is significant portal hypertension. So going into the variceal hemorrhage, the way that they measure that is EGD. EGD is your gold standard, and that is recommended at the time of diagnosis with cirrhosis. And once you have that, or once you start looking for the varices, you want to make note of any presence or absence of red spots, because that will indicate bleeding. So absence would be a good thing. And so this variceal hemorrhage is diagnosed when EGD presents one of the following. So you have active bleeding from a varix, which is your red spots, a white nipple which overlies the varix, clots overlying a varix, and varices are present with no other potential source of bleeding. Once you diagnose the varices, you have two sizes. It's very easy. You got small and large. So small would be smaller than 5 millimeters in diameter. Large would be larger than 5 millimeters in diameter. In the case of a 3 classification system of small, medium, and large, all you have to do is just erase medium and treat medium as large, and everything works out. So this leads me to my quiz question. So when would wedged hepatic venous pressure be least reliable to measure portal hypertension? When the patient suffers from alcoholic cirrhosis, when the patient suffers from non-alcoholic cirrhosis, when the patient has an increase in intra-abdominal pressure, or when the patient has a decrease in intra-abdominal pressure? You all guessed correctly. So it is when the patient has an increase in intra-abdominal pressure. Great job, guys.
So I'd like to just talk about some non-pharmacological treatments here. The first one is EVL. This is just basically banding, and it's used to first prevention of variceal hemorrhage if non-selective beta blockers are contraindicated. Also used to treat acute variceal bleeding, or in conjunction with non-selective beta blockers for secondary prophylaxis. There's also sclerotherapy, which is another option of treatment, and this is when they inject a solution into the veins to cause some clotting. There's also TIPS, which is reserved for uncontrolled hemorrhage and bleeding despite treatment of pharmacological therapy or plus endoscopic therapy. And then there's also the balloon tamponade, and this is just a temporary measure to stop the bleeding, and it's a max of 24 hours. And you're going to want to go ahead and move on to EVL or sclerotherapy. Next, I'm going to move on to some pharmacological therapies. So for primary prevention of variceal hemorrhages, if there's no varices, we're going to repeat EGD every 3 years or annually if hepatic decompensation. If there's small varices with Child-Pugh scores B and C, we're going to do a non-selective beta blocker. And then if there's medium or large varices, we're going to do a non-selective beta blocker if EVL treatment is not used. Secondary prophylaxis, we're going to do a combination of non-selective beta blocker plus EVL. And then the non-selective beta blocker we use is propranolol. For acute variceal bleed, we're going to want to probably do a blood transfusion. We want to maintain the hemoglobin around 8 grams per deciliter. We also want to have antibiotic prophylaxis, and our options are ciprofloxacin, Bactrim, or ceftriaxone. And then also we use octreotide, and some alternatives for octreotide are vasopressin, nitroglycerin, and terlipressin.
Now for our final question, we have a patient case. A 54-year-old male came into your floor with non-advanced cirrhosis, acute variceal hemorrhage. He states he's been experiencing nausea and vomiting for the past couple of days, and it actually felt worse when he tried to take down breakfast this morning. He denies alcohol use, smoking, or previous antibiotic use. So what would you recommend in terms of prophylaxis for this patient? And if you guessed option 2, you would be correct. So ciprofloxacin 200 milligrams IV twice daily was going to be the best choice in this patient. Norfloxacin would be appropriate, however it's not available in the U.S. Ceftriaxone would be a good option if the cirrhosis was advanced or if we were worried about quinolone resistance. And then Bactrim can also be an option, however this patient does not appear to be tolerating PO as of right now. In conclusion, acute variceal hemorrhage usually comes from the gastroesophageal varices, often caused by liver cirrhosis. You want to admit patients with suspected acute variceal hemorrhage to the ICU. Be sure to provide IV volume support and blood transfusions if they need them. Perform EGD within 12 hours to diagnose. The blue tamponade should be used temporarily. Start pharm therapy if the hemorrhage is suspected, and continued for 3 up to 5 days after confirmation of the diagnosis. And make sure you just start short-term antibiotic therapy in any patient with cirrhosis and GI hemorrhage. These are our references, and these are more references.